testing for and treating asymptomatic low testosterone. Certainly not a standard of care, something that's probably really frowned upon, something that if you said to an endocrinologist might make their head explode.
I've sometimes seen guys who come in like, yeah, I don't think I feel particularly bad. And after, a good discussion about pros, cons as such, ended up being like, yeah, I want to go for it. Actually noticed within the first few months, more energy. He felt more resilient. He felt like he handled stress better. And so that no symptoms thing is, it's quite difficult to tease apart.
All right. Welcome back, everybody, to the Healthspan podcast, where we talk all things health, hormones, and staying hard to kill. Today, we have a very special guest with us, Dr. Max Draper. He's a TRT and hormone replacement specialist out of the UK, and the author of a fantastic new book titled Testosterone Decoded, Understanding Testosterone, TRT, and Male Hormone Health. And that book is, for folks who haven't seen it or read it, definitely check this thing out. I mean, it's a great read for both, for prospective patients, current patients of TRT, clinicians who are interested in testosterone replacement therapy, or more important, maybe even ones who aren't interested in it, so they can get a little bit of knowledge about, what their patients are talking about and how, stepping outside the guidelines might be a good, kind of a good thing to take a look at. And the subtitle of your book, a practical guide to the importance of testosterone for health, consequences of deficiency, and the options for restoring hormonal balance by a doctor who needed TRT to reclaim his life. Right. So that's I think that's a great kind of lead into maybe tell us a little bit, for folks who don't know you. A lot of our watchers probably will. But tell us a little bit about yourself, how you got into doing this kind of medicine, and where you're taking it.
Yeah, well, thanks for having me, Mike. It's a pleasure to be on. As I was saying before we started recording, really enjoy your content, so it's a pleasure to be on with you. Yeah. So I was a sort of classically trained general practitioner over in the UK, working within the NHS for kind of the best part of 10 years until I kind of left that role about 2.5, 3 years ago. And it was all basically inspired from my own health journey. So my sort of journey or experience of low testosterone started when I had testicular cancer about 10 years ago now, so about the age of 29. And following the testicular cancer, about 2 years later, I had viral meningitis. So I had sort of like two sort of health knocks, and sort of subsequent to the viral meningitis particularly, I developed sort of what in hindsight turned out to be low testosterone symptoms. But because of the sort of, I don't know, I'd maybe call it the general lack of knowledge, awareness of testosterone deficiency and how it affects men, including my own lack of knowledge, I went undiagnosed for the best part of 3 years. And so, because my symptoms weren't classic, I didn't have like ED, I didn't have particularly low libido, I wouldn't say. Mine was predominantly sort of mental health and sort of just unrelenting exhaustion. It was put down to sort of, stress, having young kids. It was put down to mental health disorder. It was kind of post-viral burnout, that sort of thing. All these sort of labels. And when I did eventually find out it was all low testosterone related, or at least a large section of it, kind of, my lack of foundation due to the low testosterone, when TRT really changed my entire life, that's what really inspired me to be like, what the heck is going on here? How did I not know more about this evidently very important hormone for men's health? And so that kind of inspired me to go down this rabbit hole, I suppose. And like you probably appreciate, is once you go down one rabbit hole, when it comes to, say, testosterone and how we view testosterone, how we check it, how we analyze the levels and what we do about it, you end up going down all sorts of different rabbit holes, whether it's lifestyle, it's nutrition, supplements, it's all these things that we really never got that deeper teaching on during our standard training. So it was inspired from my own journey. That's why I ended up leaving the NHS GP role and sort of delving into more sort of men's health optimization, that sort of vague title, I suppose. Yeah.
Awesome. Yeah, it's important work for sure, and it's nice you have all this extra time with your patients. I've heard you mention on other shows too how you've gone from this 40 a day model to like, man, I had a busy day with my 8 patients today,
Yeah,
which is nice because you have the time. You're not sitting there worried about the next patient who's waiting. Well, you can be present and mindful and listening to the conversation and take it where it goes with the patient, whatever they need to address. Not worried about the waiting room stacking up, and it's a nice way to practice medicine, no doubt.
100%. That's been, barring the knowledge acquisition that I've been through that journey, just this sort of the new role, the new model of seeing patients has just been such a game changer. I mean, I always say this, but I couldn't imagine going back into that role. So I'll give you,
sure.
so for example, like, the NHS, it has certain positives and negatives to working within the NHS. One of the positives is getting a really good NHS pension. So obviously, if you leave the NHS, you lose that you're not topping up that pension anymore. So my wife sometimes will mention, in passing, she's not pressing me, but she says, if you went back and just maybe worked half a day a week in the NHS, you'd still be topping up your pension. And I'm like, yeah, but I just can't. I can't do it. I can't do it purely for that pension wallet. It's just such a different. You'll probably feel the same. It's just like it's chalk and cheese what we do now. What I do now compared to what I used to do. It's just like it's a different job.
Oh yeah, once you know, it's hard to do the other without a doubt.
Yeah.
Without a doubt. Yeah. So, and I think an important point in there too is seeing a provider who understands a condition is a super important thing, right? Someone who has a deep knowledge and an interest in it, and it doesn't always mean they have to have had to have lived through or be living with that condition themselves, but it sure doesn't hurt, right? So I'll have people ask me all the time, how do I find a good TRT provider, or they have some complaints or concerns about their primary care doctor, their endocrinologist, urologist, and the treatment that they're getting for their testosterone replacement therapy. And they ask, hey, how come this guy doesn't know what he's doing, or how come he doesn't take the time? One, they don't have the time because they're trying to see those 40 people a day. They might not be interested in it. They probably didn't learn a whole lot about it other than a blurb on studying for one question on a test about testosterone maybe, and then that's really it. No, not a whole lot of teaching in school about this. So I'll tell them, you might luck out, and if your primary care endocrinologist, urologist happens to be on testosterone himself, you might have hit the jackpot, right? This guy's going to be interested. He's going to have some knowledge. He's, hopefully he's doing it right for himself, and he wants to do it right for you. But there's something to having someone who has this kind of shared experience and knowledge without a doubt, I think.
Yeah, I think it's sort of like I always say that I was quite on the extreme end of symptoms in terms of low testosterone, but I think it's just the case. It's like, all of the guys in this world that we know of, the providers, whether it's even on the female side as well, it often, vast majority of the ones that we know, I think, have all experienced some hormonal side effect to themselves. And it does seem to be that, I think it just naturally happens that if you experience it yourself, you end up diving into it deeply, particularly when you've already got a medical background. And just the way that the structure of our education is sort of laid out, I think without something inspiring you to kind of look into it more in depth, you just never sort of really go down that route and learn more about it. I mean, like you said, not everybody will need to be on it, but it certainly would seem that a lot of us have experienced some form of hormonal issues ourselves, which has then inspired us to kind of go deeper than we were originally taught to. And whether it's or it can be, I know a colleague who experienced it with a patient who came to see them, had loads of symptoms, again similar to my symptom sort of list as such, but then TRT really changed his health. So that provider was inspired by a patient scenario. So you can sometimes get it through the patient journey as well. But I think you have to have something that kind of switches a light bulb on for you, because otherwise it just doesn't naturally occur in your education journey.
Yeah, for sure. No, I think it's a great way to put it. Yeah, some sort of an extra buy-in to have that, to get that provider or prescriber hooked in there. So I think that kind of ties in nicely too with the topic we're throwing around for here for today, and that's the idea of maybe testing for and treating asymptomatic low testosterone. Because it's really something that's not, certainly not a standard of care, something that's probably really frowned upon, something that if you said to an endocrinologist might make their head explode. Because the way it's treated now is you have to have very low testosterone by any standard and symptoms on top of it. And sometimes we get these people come in this gray area, or they just got something tested. They see a number and it's low. We're like, well, now what do I do? What do I do with this information? So, and it's interesting, with you too, because your symptoms too, you weren't really sure what was going on there. So it could have been, it could have been something that's very, very easily missed. So how do you, how do you handle that patient who comes in to you? Maybe they say, hey, I don't know, I just want to get screened. I'm not having any particular symptoms. They come in and their testosterone is low or borderline. What's the talk from there?
Yeah, I mean, so the first thing you'd think about there's different avenues you can go down with this scenario, isn't there? It's kind of the first thing you'd think about is, was it tested appropriately? So the classic scenario would be, was it done sort of in the morning? Had you eaten? What was your were you ill? Was there anything basically that makes that test an unreliable test, or a test that we would not say was optimal for analyzing or reviewing? So you'd probably just check off those boxes. So let's say, you weren't acutely unwell, you weren't you hadn't been on a night out the night before and drank 10 pints of alcohol or something. It's kind of like all of the sort of silly practical aspects you'd want to tick off. Yeah. And the other thing, I suppose, because like you said, there's sort of this grey area here of symptom analysis. And I think even when someone comes to see you with low testosterone and symptoms that could be low testosterone, the debate is often, is the testosterone driving the symptoms, or is the low testosterone a signal of like a dysfunctional lifestyle, for example? It's kind of that chicken and egg situation. When someone comes in and they say, like in this scenario, let's say it's a genuinely low result, maybe they've got a couple of low results, and you're looking at it and you think, yeah, this looks like a level that's pretty poor. Let's say in American units, I don't know, 300 total, 250, so it's definitely kind of on the low. It's not like even in a grey area. And then you say, well, do you actually genuinely have no symptoms? Or, because what is a symptom when life is so much about perspective and you're really comparing yourself to yourself, because you can't experience what someone else feels like on a day-to-day basis. And that's sometimes key, because I've sometimes seen guys who come in, let's say, there's one who sticks in my mind. He was in his 50s and his level of testosterone came back at sort of, I think it was about, in your units, it'd be about 250. It was kind of like 7 or 8 in the UK units. And he was like, I don't think I feel particularly bad. And after, a good discussion about pros, cons as such, he ended up being like, I want to go for it. He actually noticed, within the first few months, more energy. He felt more resilient. He felt like he handled stress better. And so that no symptoms thing is, it's quite difficult to tease apart as well, even in that sense, because it's kind of like, well, if you have no symptoms, but you've got a lack of response to training, is that a symptom then? Because that's so multifactorial. I suppose I'm blabbering on because it's so complicated. That's why we do take our time with people. But yeah.
No, I think that's an excellent point. What I was hoping you were gonna bring out actually is, are you actually asymptomatic? Right? Because what are the symptoms? Because it's usually not an overnight thing. It's not like you woke up with with a virus and you have a fever and you feel awful one day. You went from feeling 20 to feeling 70. It's it's a gradual decline, and you can explain it away, like you said. I have some. We were talking earlier about could it be kids keeping you away? Could it be could it be your work stress, some home stress? You're just getting older, right? That's the common thing people hear all the time when they go to their primary care doctor. It's just, you look great for your age, or you're doing great for your age, whatever it might be. So you have this kind of slow slip, and if you don't know what it could feel like if it was corrected. It's hard to know if you're symptomatic or not. So I think that's a great point. And also too, with the correct testing, a lot of kind of traditional testing, they'll get a hard time on the forums about, they want to do multiple tests and they want it to be real specific. But that can be important. I had a case just this week with the guy who came in. He had multiple results in the total testosterone of 100, so super low free testosterone. I mean, just negligible, single digit. And I retested him, and he was in the 400s. So still not fantastic.
Yeah.
But also we got to talking a little bit, and on the second volley of talking, he left us out the first time. But he had some significant stressors, like, oh man, I wasn't sleeping good. I had a lot going on with those other tests, and okay, so it can make a pretty big difference. Not to coach people on how to get a low testosterone reading, but stay up all night for a couple nights drinking and partying and stress yourself out, and you can have some pretty low numbers there.
Oh, 100%. Yeah. And that's what's so key about sort of, I suppose it always comes back to seeing the right provider, the right person at the end of the day, because I've listening to your stuff before and meeting you before, and the guys that we often communicate with is we're not in this to try and sell you on testosterone. It's not like, we want you to get a low result so that then we can fill out a prescription and then get paid for it. It's kind of like, is this genuinely in your best interest? So getting an accurate result is really key for that assessment, because like you say, if you're ill, if you've lacked sleep, things like that, you're not giving yourself a true reflection of your day-to-day normal existence, which is actually what we're looking for. We're looking for, does this level reflect your day-to-day normal kind of life? And that's what's key to how to work things out. And again, you could caveat this with saying, how much do we obsess over the numbers versus the symptoms? Well, the reason this is even more important in this scenario we're talking about is we're saying these patients don't really have strong symptoms, so the actual blood accuracy is even more significant now, because we need to know long-term health-wise, is there more pros to it than faff with going on TRT, I suppose, is why it's even more important to get an accurate level.
Right, and that's one that comes back to one of the bigger things too. Is why don't you just treat the low number? Is because it is considered kind of a like a lifestyle medicine choice and not a completely necessary treatment. You're not gonna die without it. You might not feel great. You might wish you were wish you were dead, but no, not quite that bad. But it's not like let your diabetes run unchecked and now you're going to lose a leg, or hypertension and now you're going to have a stroke. So it's not going to be a comfortable decline, but so there's people tend to be more cautious with things that are more elective than 100% necessary, right?
Yeah.
But that said, there are some. So it's back to what are some things that could benefit though, because there are some health benefits to having adequate testosterone levels, and some big negatives to having low testosterone. And it kind of shows up in some of the bigger studies we've seen. I think kind of one of the more glaring ones is even all-cause mortality.
Yeah.
Right. So just dying for any reason. If you have low testosterone, there's some connection there. Now, are we talking about association does not always prove causation? Someone's always going to come back and say that too. Like, hey, were these people just sick anyways? You're checking testosterone levels and someone's sick. Like we just said, your numbers are gonna be low. But there does seem to be a little something to it. People just, you're more vibrant, you're living life, you're out there enjoying things and healthy and happy. So I think that point there's actually something to it.
Yeah, and I think you're spot on. It makes sense, because I always go back to the basics. It's kind of like, right, if you just said to someone, do you think having low vitamin D for 20 years is better than having, good levels of vitamin D in your blood, and do you think that your health outcomes would be worse with low vitamin D than they would with good vitamin D levels? And naturally I think most people would assume probably low vitamin D long term is bad for you. Same with like an underactive thyroid. So I think sometimes testosterone is unnecessarily complicated when the wider media refer to it, because there's still this kind of bias against it which doesn't exist against other things, thyroid interventions, even things as silly as the association with PEDs. Well, bodybuilders use insulin, and we don't talk about, we don't look at suspicion with type 2 diabetics who end up going on insulin eventually. The same thing with thyroid. A lot of bodybuilders are using thyroid hormones, but I think it is again, when you go back to the simple basics and you say you've got a hormonal deficiency, just in the very nature of that, do you think this is going to be long-term good, bad, or neutral? And I think most people would then, even if you just remove the word testosterone, would come out with saying, that probably would be worse for me. Like you said, it does get complicated because when I was researching for the book, I was looking at sort of, to give an example of like cancer. So personally, I suspect that if you've got low testosterone, your rates of getting malignancies, cancers, might be higher because testosterone has a role with inflammation, visceral fat, insulin resistance, sort of immune system function even. So it's kind of like, do you think that men with low testosterone long term are higher risk of developing cancer? Well, I can't say that from the research, but the theory would certainly, at least in my sort of opinion, may well support that concept. But again, men with cancers, particularly bad ones, are often diagnosed with low testosterone. It's kind of like you said, is that because they've got cancer, or was it chicken and egg again? So this does get complicated, but I think at a very basic level, you could say, I think men with low testosterone, I think it's fair to say that there's certain risks associated with that long term, which is why this idea of necessarily just removing it for purely symptom control is a little bit seems a little bit naive in that sense, really.
It would be nice to have some data too if we were just checking this more regularly to see. Then we'd be able to see, hey, we have these guys were young and healthy, and then their testosterone was still low and they had a higher rate of cancer or not, right? It would be some long-term study and have all this data. But if you're not checking, you're checking at the wrong point, or only at one point, right? You don't have these multiple data points to be able to make some decision about what you think is actually happening there. So it's a tough one. It's a tough one. But even like you were saying too, can it add to, if you're improving all these other factors that are, quality of life factors, is that going to reduce your chance of cancer? It sure seems like it. Even just, testosterone makes you more stress resilient, and your body sees stress all in one basket, right? So, if you're living a chilled, relaxed lifestyle, you're less likely to get sick. You're less likely to get a lot of different things. So there's something to it. There's something to it without a doubt. Yeah, it's an important one.
I think the evidence in general for sort of low testosterone risks, I think it's definitely fair to say that, obviously anemia is a big one, particularly for older guys. You don't tend to see it so often in the young guys, do you? But there seems to be older guys can become anemic. Bone health. The
younger guys are worried about it on the other end, right? We see them on the forums. Yes. Oh, my hemoglobin and hematocrit is too high. What do I do?
Yeah, right? Exactly. Yeah, and that's how I kind of explain the impact on hematocrit to people, because often when you see them at their first initial consult, I see it quite commonly where their red blood cell count might be a little bit low, their hematocrit's the lower end of the scale. I say, you see, when you go on TRT, this is going to reverse, where we're going to see a little bit higher levels, and that's kind of what it does. That's how it works. But bone health, anemia, so bone density, lean body mass, so body composition. You talk about obviously sexual function, which is, I think we overlook sexual function as just, that's cool, everybody wants to have. But actually in terms of long-term mental state, confidence, relationship health, all of these things then impact your long-term sort of well-being as well. Then you would talk about sort of, maybe the evidence is not as strong, but I think it kind of speaks downwind of those things, is insulin sensitivity, mood, potentially even dementia, cognitive issues, and cardiovascular disease, sort of low testosterone. So I think, like you said before, the problem with these things is they're so multifactorial. But a lot of this stuff is, if you look at the studies, it says it looks like low testosterone is an independent risk factor for the development of this, which I think is quite a key wording, really.
Oh, without a doubt. Yeah, that's always what you're looking for too, right? You don't want to see what kind is just some correlation study that just means nothing, right? Who knows what it is? But yeah, some of these, it seems like they fleshed it out. Like, hey, no, there's some extra percentage points happening here. There's some goodness where we're maybe don't fully understand. And on the diabetes side of it too, I think it's something like a 40% decrease in type 2 diabetes, something like that, with adequate testosterone. Or even supraphysiologic testosterone. That was the interesting part about one of those studies too. They said, hey, actually, if you push it a little bit, and not crazy high. I'm not talking bodybuilder doses. I'm not talking about 3,000 nanograms per deciliter kind of stuff. But getting it up in the high. It would have been a high normal 10 years ago. You're 1,100, 1,200 for some guys, and or maybe not. At least normalized. It seems to really improve diabetes, and that's huge. I mean, that's amazing right there.
Yeah. Well, particularly when you kind of look at long-term outcomes from diabetes, if you can kind of reverse or avoid that, it's so huge for your long-term health, particularly in the Western world. Like, speaking to someone who's living in America, it's even worse there than it is for us over here in the UK. But, type 2 diabetes and the sort of the plethora of issues that leads to, not only in terms of how you feel and function, but long-term health is terrible. So if you can kind of get on top of that and help avoid it, it's huge for you, but also the society as a wider concept as well. So I think that insulin sensitivity aspect is a really big in the pro testosterone corner, I think, ultimately.
Right. Yeah, and it all comes together too. I know you're a big proponent of lifestyle is hugely important, and if you're not doing, I tell my patients, if you're not checking these lifestyle boxes, the hormones just aren't going to work. I mean, is that a little extreme and maybe overstating it? Maybe, but it's pretty close, right? You're going to be pretty disappointed if you're not doing those lifestyle things. But yeah, you get someone who's diabetic, who's not exercising, you get him on a little testosterone because he's low. Replace that. You get him in the gym lifting some weights, just even a few times per week. Now he's using those muscles. Those muscles are, glycogen storage tanks. He's burning and using glycogen, way more, insulin sensitive. Boom, we reverse his diabetes. And gets off 2 or 3 medications or maybe all of them. You can see some amazing stuff. So I think even that alone, even for, treatment of diabetes. I mean, and that's something I would consider for someone coming in. If someone comes to, to my clinic, that's an easy call for me. If someone comes in, they're diabetic and they're low and they have low testosterone. Unless we have some other reason, not to, like there's some big immediate fertility concerns, man, it makes some changes. I'm a fan. I'm a fan there for diabetes.
Oh yeah, 100%. It's funny, as I was talking honestly about the lifestyle side of it to my wife just on our walk this morning, and I just said to her, the thing about nowadays is, I agree with you in terms of the hormones won't work unless you're hitting the lifestyle stuff. And I don't think that would have been the case 30, 40, 50 years ago, because lifestyles have changed so dramatically in terms of you can't be normal now and be healthy, functioning long term, particularly as us guys get older. So if you're hitting your 40s and 50s and you are living the life of the average 40 to 50-year-old, irrespective of TRT, your long-term health outcomes don't look that pretty, because we need to actively be against the grain in terms of going for walks, doing general movement, exercising, training our muscles, cardio, looking after our diet, not just buying the stuff that's easy and to hand to eat. Because if you just go low resistance day to day, you will end up with poor outcomes. You will be overweight. It's almost inevitable. Do you know what I mean? You probably won't feel that great mentally. You probably won't sleep that great because you're not active enough. So I think, when you say, you have to hit the lifestyle factors for the hormones to work, back in the day with our parents, grandparents, when people were biking all over the place, they were going for, they weren't in the car as much, their jobs weren't as sedentary, you had more manufacturing stuff, all of these things where people were generally lean. I think you could get away with just saying, lifestyle, you're ticking the boxes because you're active. But nowadays, I think you actually have to be not necessarily obsessive over it, but I think you have to make plans to sort of navigate the modern world. I'm not saying that modern world is bad, but I think it's allowed people to take the low resistance route, which does not end up in good health outcomes, really.
Yeah, you traded one, you're trading one convenience for. Or trading convenience for comfort, and things can get a little bit flipped around, right? So you have this built-in exercise. Life is hard, and you have all this built-in exercise, and you're out, having to hunt your food, and worried about running away from a predator, all these terrible things. Yeah. And now you're safe in your air-conditioned house and all these other bits. But now it's harder on the other end. You have to make time for that activity. It's not built into your day. It's not mandatory for your immediate survival, so it's not top of the list.
100%. I think you're right. We've got the better end of the trade-off, but we just have to be mindful of it.
Right.
Like you can't just go low resistance, order Uber Eats and kind of watch Netflix all the time. You've got to really be thinking, actually, I probably need to make a bit more effort and actually be a conscious effort, whether I'm on TRT or not. So I just think it's important to specify that, because the average lifestyle does not communicate to good results on TRT, because it doesn't really communicate to good results long term anyway.
Right. Yeah, we have someone will pop in and mention some of the high dose studies that were out there too on testosterone. Well, if you take 300 or 600 a week, you can actually get some results without the gym. But that's a little silly. I mean, if you're doing that, man, you really better be leveraging that. And it's a little, you don't need all that. So yeah, fantastic stuff for metabolic health, right? I mean, you're reducing metabolic syndrome, insulin resistance, visceral obesity, right? You're reducing visceral fat. Everyone wants to reduce visceral fat, and they don't want to, maybe they don't want to actually do the work on it. They want to take a peptide instead, because they think that's gonna do it.
I think one of the biggest markers you see improve with TRT is the triglycerides, isn't it? The fasting triglycerides is often something that does crop up on a regular basis. People with low testosterone, you'll often see them with that high triglycerides, which is a good marker in terms of blood work for visceral fat levels. It's kind of quite neatly aligned in some senses. No blood work is perfect for it, but you often do see triglycerides lower over time, particularly if they're ticking those lifestyle boxes. Yeah,
triglyceride level is a great level. I think a lot of people kind of brush over it quick, like, oh, your triglycerides are a little high and they're creeping up, year over year, and people, they're a little high, we'll keep an eye. No, this is a red flag, man. This is some early metabolic syndrome, or maybe not as early as you think it is even. We need to do something about this. So it's a huge thing. It's a huge thing. Yeah, and you mentioned, cardiovascular health. So that's quite a flip too, right? Because that was the old thing too. Oh, testosterone terrible for your heart, all these things, and it seems like that's maybe been disproven here.
Yeah, I kind of look back and think, where did that original thought come from? Because it almost feels like the old evidence was trying to prove that it did. And was it because men have more heart attacks? Was it because, I don't know, I suppose it predates the use of anabolic steroids, but obviously anabolic steroid users often, if they do run into issues, it's going to be often heart-related stuff, whether it's heart enlargement or heart vascular disease or arrhythmias and things. But did it come from this idea that men suffer with heart attacks more? So is that because we have more testosterone? I've never quite got to the sort of down to the nuts and bolts of why it was almost the original precursor thought that testosterone was bad for your heart. Because if you look at the mechanism of action and the sort of the role with nitric oxide, estrogen creation, like you said, metabolic health, helping lean mass, helping sort of avoid visceral fat or reduce it depending on the situation, you just think, well, actually that sounds quite pro cardiovascular health, all of those aspects. But it was almost like we almost had this precursor thought that no, maybe because men suffer more than women from heart attacks, it must be the testosterone. I don't know if you have any ideas as to why it was sort of the original thought was always we had to disprove it was bad rather than start with a neutral stance.
Right. No, and I've not seen any real good actual evidence that pointed to that either. It's very strange. It definitely is stuck around in the you go see your cardiologist, and there's some very forward-thinking ones who are up to date on all this stuff. So I've had a few interactions with some that are very super open-minded, like, oh yeah, no, let's fix this guy. Let's get his levels back up. And some that are just sit back in these ways, but they learned however long ago it might have been, and they're just dead set against, like, oh, there's no way, this is going to make everything worse. I know there's there is some trial data, like from Traverse. They said, oh, maybe there's a little bit of a bump and an increased chance of something like AFib. There's a pretty insignificant difference in there. And also Traverse is just, I don't know. As nice as I like to see, we have this big trial to kind of prove some safety data, it's a pretty garbage trial, because it's really not the way we practice at all. We're not using the product they're pushing. We're not taking people to the levels they're doing. We're not cutting them off the way they would if they got too high. So I don't put a lot of weight on that. And it doesn't show up in some of the other trials either. So that's a little suspect.
Yeah, and I saw rather, I can't remember who it was exactly, but I remember them being quite well-known online influencers or physicians or practitioners saying that, yes, the Traverse was reassuring about cardiac heart disease risks on TRT, but they weren't taking patients to the levels that these clinics are taking it to them. And I was thinking, yeah, that means I would be more confident about getting better outcomes, taking them higher in terms of what you do see in practice.
Excellent take on it.
Yeah.
Maybe that's why they didn't get better outcomes, right? Yeah, we could be reducing it even more.
Well, that's the way I felt about it. And again, it's so difficult because, like we were saying earlier about collecting data, looking at causation versus, sort of correlation, and all of these things are so multifactorial. So that's why people often miss is, to study what we do long term. We've got our own patient cohorts, and we're seeing they're not all blooming dropping dead of heart disease and things like that abnormally, etc., etc. But to really make meaningful data, you need to take so many people and study them for such a prolonged period that it's hard to say that's going to be done. Do you know what I mean? So we kind of use what we've got. We use the physiology of testosterone, what we think and know it does in the body, and then we do use the data like the Traverse studies that we have got, because we can't really lean back on loads and loads of data. Although there's been lots of studies, what we're talking about and what we're doing is kind of extrapolating from all of that, and we don't actually have the exact say if you take this person to 900 over the next 10 years, that's better than taking them to 450, let's say. I mean, for many reasons you could extrapolate it will be, but it's hard to say we've got a Traverse-esque study to back that, really.
Right, and we probably never will.
No,
exactly. Doesn't seem like we will. I don't know who's gonna fund that.
Maybe the army. Maybe the armed services in the US.
I was gonna throw that in here. That's a good point to maybe put that in here too. Yeah, before when we arranged this, this interview, some weeks back, was before we heard that announcement by the U.S. military and the Secretary of Defense, Pete Hegseth, about testing testosterone in all service members over the age of 30. So you're right, that would be a huge data set. What an amazing, right? I mean, for all the things government does wrong, they have some, collecting data is something they seem to do pretty well. It would be super interesting just to see it, even if no one did anything with the information, even if they just checked it and no one was treated and there's nothing else to it. It'd be super interesting to see how does it correlate with the rest of their health. I know it's a special population too, with special needs, extra stressors, extra lifestyle factors, but it would be very, very interesting to see. That's all over the internet here. People are very upset about it for their own reasons, making it personal about themselves, including I've seen some females on TikTok yelling about it. What about women's health? Like, we're not talking about that right now. It's fine. Mm-hmm. It's a separate thing. But everything from people saying, hey, he just wants to get all of our troops hopped up on testosterone and turn them into super soldiers, to there was I think it was on maybe the Fox News, one of their shows, one of the hosts on there said that the women need to be more careful on military bases because there's going to be a higher chance of sexual assault because of the high testosterone. I just saw a blurb about this. I couldn't bring myself to actually watch the programs. Mm-hmm. It's just ridiculous. They're saying, on bases or near foreign bases, everyone needs to be more careful now. So it's interesting. It's interesting, but I think it could be helpful when you're talking about guys, especially he's talking about not testing these guys till they're 30. So a lot of them start serving in their 20s. They've had a stressful career doing some important work and helping their country. They've had some psychological and probably physical stressors or traumas, and there's a pretty good chance they have some numbers that are off. There's a pretty good chance we can make them feel better without just throwing them on some psych meds. So I like the idea of it. At least the thought of it. I don't know how they're going to implement it.
Yeah. I think time will tell what the treatment regimes will be like. If depends on which route they go down there, isn't it? But like you said, I mean, even being in the UK, I've got people like patients of mine who are ex-military from the US even. So it's kind of like low testosterone hormonal issues post-service are certainly something that needs to be considered and looked into, because like you said, the physical, the mental, all of those strains can really affect your hormones, even as something as simple as being, you know, in a traumatic exposure or nearby a traumatic explosion, and the fact that your pituitary is sensitive to those vibrations and damage. So it's certainly I was very, when I saw the thing, obviously not being in America myself, but when I saw it, I was like, that makes sense to me. You know, politics aside, it kind of does make sense to kind of add it in, because you're basically adding it in as a health check essentially, and that's really what you could look at testosterone as part of a health assessment.
Yeah, I don't think they realize they put the guys through all other kinds of stuff too, giving them all kinds of vaccinations and all other kinds of screenings. It's just an extra blip on a chart. Again, yeah, it's just a data point. You don't have to act on it. Yeah. Folks here seem to be under the impression like, no, it's going to be mandated. We had one of the forums, someone went on there and said, I want to know what everyone thinks about these guys. You know, Pete Hegseth saying he's going to make make sure that anyone under 1,200 nanograms per deciliter total testosterone gets on testosterone, so they all have super high testosterone. It's like, where'd you get that from? It just it doesn't exist anywhere. That's not a thing. It's not a thing.
That's the next step. That might be a few steps in the future. Yeah.
Sure. But I mean, if we're going to argue that too, I mean, I could see at a point, you know, if you want some of these guys super healthy and fit, some special operators or something, or whatever, you know, whatever it might be, pushing them to, you know, high normal or extra, you know, some extra something. I mean, I don't know. They're having some extra stressors. It's not the craziest thought.
No, it wouldn't surprise me if it was already in play, to be honest, that sort of thing. You know, not sound conspiratorial, but it wouldn't surprise me if they had some extra juice going in, you know, in various ways, to be fair. You just wonder, you know, why wouldn't you consider it if particularly on those special ops and things, you know?
Oh, yeah. No, we talk about, you know, athletes taking the risk of taking, PEDs, and is it really worth it as compared to just the gym bro wants to look good for the beach? Like, I don't know, this guy's making $50 million. You just want to look good for the beach. You know, short-term risk for a high reward. I don't know. You know, you're an adult. It's a trade-off. So you're talking about someone literally risking their life for some, important things. You know, I don't know. There could be something to it. But yeah, I wouldn't be surprised if there was a little bit of that going on anyway. There's someone somewhere smiling and nodding their head like, yeah, you don't know the full story here. So yeah, it'll be interesting to see how they do it, because the current system with the Veterans Administration, the way they handle it for their folks is just awful. The numbers are just super extra low. I have someone close to me who went through this recently. Went in there, just super low numbers, and his doc told him anything over 150 total T is really okay, and that's not even their standards. Even the VA has, I think maybe theirs is like 250. They want it to be right, or like 8 nanomole for you guys, something like that, something low. But this doc went an extra step further. He's like, nah, you're pretty close. Anything over 150 is okay. Completely ignored the symptoms, and he's like, oh crap, what do I do? So that's when we had to have a talk. So if that's the way they handle it, it's not going to be a great deal.
Yeah.
We'll see.
It's not going to make much difference that way. Like you said, it's the interpretation of the results is so key, isn't it? It's like testing is one thing, but in all of this, like we were saying before, it's the assessment and actually working out what those numbers mean is really the key to it. So even if they tested 1 million people, it's like, well, what's your cutoff? What's your symptom analysis like? What's your what's your treatment protocol going to be like? It's testing in itself I'm a fan of what they're describing, like you said, because of what they go through. But time will tell what actually comes of that testing, I suppose. Right.
Yeah, it seems like it would be way too high profile to just get everyone all, it's mandatory. Sorry, you have to take this. We'll come and give you your shot for you if you're not doing it. I can't imagine that's going to be a thing, but yeah, people like to believe in their bigger conspiracy. So we'll see. I think there was one other one that I thought was interesting too. Someone mentioned on a post, hey, why do all these 20-year-olds need to be on testosterone? Is this really important? So first, they weren't talking about 20-year-olds, so there's that. So he was just completely wrong there. But I replied back and said, Well, he said, how many 20-year-olds actually need testosterone? I told him, you'd be surprised how many actually guys in their 20s have some issues. In particular, these guys. Again, you have some, maybe you got blown up. You have some PTSD plus a TBI, right? I mean, you have some, post-traumatic stress and a traumatic brain injury altogether. That's going to be a 1-2 punch that could really mess you up. Living in a high cortisol environment for years and years on top of that, or even without that, can do it alone. A lot of military folks have there's a high predisposition for higher alcohol intake. There seems to be that'll mess you up a bit too. So I think probably higher than the normal population. Guys who are military or ex-military in their 20s have a lower testosterone, and maybe they should be checking them too.
Yeah, you'd think so. Plus, like you say, it's not out of this world for a 20-odd-year-old to walk into our clinics and consult with us about having issues. And there can be a variety of reasons, whether they're big reasons or a lot of small reasons that have all added up over time, that you can end up with an issue in your 20s. It's not unheard of. It does tend to be more common 30s, 40s, 50s and stuff. But yeah, I've got a few 20-year-olds. I mean, looking back, my cancer was at 29, so I probably didn't develop sort of symptomatic low levels till just a bit beyond that, but I would have been myself not far beyond my 20s. So it definitely can happen in just the general public, in the general sort of outside of the military world. So it's certainly something that you can't overlook, and I think that's probably part of the problem, is that a lot of people associate low testosterone with just older guys, but how many guys out there who are youngish, whether they like Andrew Wingy having undescended testes and having an operation quite delayed. He was low in his 35, but I have guys who had undescended testes, had operations, and they're low at 26. And so it's kind of like all of these factors have to be thought about. And how many guys are out there who are in their 20s, 30s, and testosterone never crosses anyone's mind because they're quote unquote young, but actually they end up on an SSRI, they end up through therapy, they end up on off work for the long term because they've got quote unquote mental health issues or this, that or the other, and because of their age they never get considered for low testosterone, when lo and behold, if you check it ends up coming back like you say 7-8 in my units, sort of 300 sub with yours. It's kind of like, it's important not to exclude those younger guys just based on age, really.
Oh, for sure. You always have to look at the patient in the whole picture without a doubt. And with these military guys or any guys in general too, now we're back to, hey, that would be some cool data to have, because now if we're testing this guy at 30, what if we knew what he was like at 20? Yeah. We knew what you're like at 20 before we signed you up and put you through all this stuff, and or whatever it was, or you had the decline you were going to have anyway, regardless of your service. And now here you are 30, and this is what your number is, and you feel like crap on top of it. Man, we have a slam dunk case here. But that would be some good data to have. I think another interesting point is the pros and cons of actually collecting that data or knowing those numbers, right? Because I think it really depends upon the patient and how they're going to deal with that information. If they're going to see it just as a data point and not obsess about it or worry about it, they're not they don't have a lot of health anxiety, maybe they can handle it. But for some people, it's like, man, is it worth checking? You tell me you feel great, there's nothing wrong with you, we're going to check your testosterone, it's going to come back at 400. You're going to be obsessing about this until you get on testosterone, and maybe even unnecessarily. So I think that's interesting.
Oh, 100%. Yeah. I think I spoke to Andrew about this before. I think it comes down to personality type. It's I was speaking to one of my brothers the other week, and he's very fit. He's in his early 40s. He's extremely good shape. Probably body fat percentage maybe 11-12%. Not on any TRT or anything. He's just sort of naturally active and things. And I said to him, have you ever got your blood panel done? Maybe look at your extended lipids. Do all these things that you can do now through the private sector in the UK. And he was like, why would I want to know that? If it came back as abnormal, I just have an extra thing to worry about. So it does often come back to personality types, what you want to be looking at and how you feel. Because certainly for a lot of younger guys, I think sometimes, like you said, the reverse scenario of being aware of low testosterone and the impact is also being aware of the psychological role, the role that your psychology has on how you feel. So if you come back with a level of like 400, like you say, and you felt fine, but then all of a sudden you start to think, well, are my erections as strong as they should be? And you kind of get into your head, how's my libido? I mean, thinking about your libido is kind of counter to your libido. So it's like,
right.
It's all of these factors, particularly with sexual stuff, your psychology is
fulfilling
quite
prophecy
important
there if you go down that, get on that road.
Exactly. Stressing about your libido, for example, is not the best thing to do. So it's kind of like it is a balancing act. I suppose the individual has to take the sort of personal decision as to whether they want to look into it, particularly if they're feeling okay. That's the key question.
Yeah, without a doubt. It's interesting too, because in contrast with other things, I would see this in some of the primary care work I've done. People don't check other numbers or other things because they don't want to know about it, or they saw it was off before, so they took some measure and just never wanted to check it again. Like hemoglobin A1C and diabetes is one of those I would see all the time. Like, oh no, I knew it was high, but I just changed my diet and I lost 10 pounds and I just never checked it again. It's like, well, now it's instead of an A1C of 7, now it's 12. So it's a problem. It's a problem.
Yeah.
We need to check it. Well, I feel fine. It's like, do we let that go until you're symptomatic? Are we going to wait until you're, you have a black toe, or you're, having frequent urination, or you go into DKA or something, and then we check? Yeah. So you kind of put it there, and can you call testosterone that extreme? No, because no one's gonna lose a foot if they don't go on testosterone. But they're long-term health things. So it's somewhere on that spectrum.
Yeah, that's a good way of describing it. Sort of on that spectrum, like you say, is maybe diabetes at this end, cholesterol somewhere on that spectrum, depending on which way you sit on the sort of whole cholesterol debate, and then you've got your testosterone somewhere on that scale as to sort of, because it's not long-term good if you have missed low testosterone, but it's not as severe as, let's say, having uncontrolled diabetes that you waited and never tested. That's probably more significant, that sort of is a bigger factor to check. But yeah, 100%. I think that's just the awareness that, because online we'll talk about low testosterone causing symptoms. We'll talk about how TRT can be life-changing if you're really suffering from low testosterone, but we don't really broach too much about the long-term health outcomes. So I think that's why the chat was important, just to explain that actually there's some logic to correcting it potentially because of the health, and the functionality, particularly for older guys, keeping your muscle, keeping strong bones is pretty important.
Exactly. Yeah, we're talking about, we're talking about all-cause mortality to kick things off, and just, staying healthy, and, health span being more important than lifespan. You're right. I mean, sarcopenia is just, you're dying slow. You wait for something bad to happen. You're going to, you're under muscled, you have a fall, or you have a setback, or you're in the hospital, and you're laying in a hospital bed, losing 10 pounds of muscle you don't have to lose. You're not going home. That might be it. You're going to a nursing home, and that's going to be it. Or bad things happen. So that's hugely important. And I'll have that talk with some older guys sometimes now too. Guys in their 70s. Hey, actually I feel great, and they're super active. They look great for their age. They're probably a little under muscled though, because they'll ask me, "Is there anything really I'm missing out on?" It's like, honestly, man, this might be it. I mean, they're still going to the gym. They're still lifting. I know what they looked like before. Some of these guys, I've known them. I've known them for years. And it's like, hey, there could be a little bit something to this. I mean, we don't sell or push testosterone as a muscle builder or a bodybuilding thing. But we're talking about the difference between, mass monster versus, you've crossed the threshold into sarcopenia. This is a health issue. We're not talking about, this isn't steroid abuse. This is going to keep you alive and well. It's huge.
Yeah, 100%. I think people have become more aware over the last maybe 5 years. You see it more online talked about, is the significance of muscle, skeletal muscle with healthy aging. And that's why, we're not just talking about, when we talk about lifestyle and talk about resistance training and things, it's really not just for, looking good or aesthetics, having big guns. It's about actually, your muscle is like your savings account, particularly as you get older. It's just, if you go into hospital and you've not got much savings saved up, well, you might be in trouble when the sort of the health bills, let's say, come in terms of your actual physical health rather than actual paying for your healthcare. But I mean, it is true. It's your kind of it's a big factor in your resilience. It's like essentially like people who are doing crosswords to try and keep their brain active. Well, keep your muscles going as long as you can and as strong as you can, really.
No, it's important. It's a huge thing. All of my patients, I mean, they hear it from me all the time. If they're not working out, if they're not lifting, doing some resistance training, like, oh, I don't like it. I tell them do it anyway. Kids say they don't do things because they don't like it. That's for children. There's a lot of things in my day I don't like, but I do them anyway because they're important, right? You don't have to love it. You don't have to go 6 days a week and get crazy about it. But you can give me 2 days a week for 30 minutes to do some resistance training. That's gonna move the needle, especially if you're doing nothing. So I need them to get after it. It's a big deal.
Yep, 100%. I think as well, like you said, is the beauty of a lot of this lifestyle stuff is, if you look at the data, the going from nothing to something is almost like where the biggest change can happen in terms of long-term health. Mm-hmm. It's like steps, it's kind of, everyone talks about 10,000 steps a day, but going from like very few to some is actually a big needle mover. It's obviously not the optimal, but often we have to meet people halfway, and you don't necessarily need optimal outcomes, you just need better. So doing something is significantly better than doing nothing, and that's what's key to understand. Like you say, if you can bang out 2 half-an-hour sessions a week, then that can make a significant difference.
Yeah, all people tell me, I don't even have time for that, and they'll list off all the things. Their kids have 9 different activities they have to do. So I'll tell them, twice per week, there's some point where you're unwinding at the end of the day, you're watching some TV. When a commercial comes on, I want you to give me a set of push-ups. If you can't do a set of regular push-ups, modified in some way on your knees or on the coffee table. Do that for 2 or 3 rounds. Maybe you just start with 1. Just let that ride. Do that for a couple of weeks. And then, after your sets of push-ups, now you do a few sets of squats. And do that for a few months. Do just 2 nights per week when you're watching TV, a commercial comes on. Now we're working our way up, and you're probably going to want to do more. Is probably what's going to happen. Yeah. But even if you just did that, it's so much better than not. You did that and took some extra walks in your day. Man, you can really change some stuff. People will be feeling good and looking good. So doesn't take a.
You want them to catch the bug. You want them to catch the bug, don't you? That's ultimately what you're after. Is people catch this bug where they're like, actually, if I don't exercise, then I don't feel right. That's what you're looking for. Mm-hmm.
Yeah, and it's a lot of, we were talking about, you're not selling testosterone. A lot of what we are selling is that. It's the whole, it's that whole package. Because I've said it before, I'm a pretty terrible salesman. I talk people out of treatment all the time. Like, man, I don't think you really need this. Yeah. Doesn't sound like it. Or, hey, let's try this first, or whatever it might be. Even more so on the peptide side. I get people call me all the time, hey, I think I need this thing. And like, I could be selling them all this stuff. Like, dude, you don't need that. Mm-hmm. That's dumb. Mm-hmm. Let's move on. Let's work on the big rocks first and get you going.
Yeah, 100%.
So, we touched on it a little bit back there too, but one of the, as far as things like mood and even psychiatric disorders and testosterone, it's a big thing, and this could be a little bit tricky too, because you would never want to claim that, hey, psychiatric medications are unnecessary and it's all about hormones and we're going to fix everything. That's certainly not the case, and they have their place and they keep people, safe and healthy and functioning, and that's my disclaimer there. But on the other side of it, there's definitely some people I've run across personally, I know you have too, where they've been inappropriately put on some some SSRIs or other medications, or sometimes multiple levels deep, like polypharmacy psych meds. And their thyroid and their testosterone is just so out of whack. And we start fixing that a little bit, and they wean off their other meds, and they're like, you got to be kidding me. I took this other crap for 10 years. How come no one told me this? So another reason to maybe to screen, but our psychiatric providers or primary care providers thinking about that when they see mental health issues, I think they're probably not.
Mm-hmm. Yeah, 100%. Well, I personally, in that sort of 3 years of severe symptoms there, particularly sort of anxiety, brain fog, sort of real sense of defeat, I ended up going on an SSRI for best part of 6 months. It was sort of like, I think I was on one for a while, went off it, went back on it. So it was kind of like, it was again, it was just you can misassign it as a mental health disorder when actually it's a hormonal problem, and that is so common. It's common enough to make us sort of talk about it on a regular basis, because how many times you see guys who come in and, like you say, they're on an SSRI, they might even be on, like you say, a couple of different psychiatric medications, and then within 6 months, maybe even 12 months, then they're off everything, and that's a huge game changer for people. Feeling mentally better. I mean, your experience of life is 99% derived from how your brain, essentially, in the sense of how you perceive things and things. So changing that in a positive sense is massive, and that's probably where the main life-changing acute attributes of TRT, when it's well done, come from, is clearing up brain fog and reducing anxiety and improving mood and motivation. I think that's probably where a lot of the positive feedback I get in that first 6 months is probably comes from. Is probably the mental side of it. Energy is a big factor as well, but probably the mental is where guys will come back with that sort of like, holy smokes, this has really made a difference, and that's one of the reasons the job is great.
Oh, without a doubt. Yeah, people, that makes the work fantastic. People calling in, and you have a nice long chat with them, and they tell you how great they're feeling. Like, this is a pretty good day. I'm going to do that 6 times today. I love it. And it's not always that smooth, right? I mean, it's not that smooth for everyone, but we get them there. We get them there without a doubt. And the other part is just taking this amount of time. Again, not everything. Hormones don't fix everything. I tell people that in visit 1, just to set an expectation. Like, man, it could be your levels are super low, and with your symptoms, I bet we're going to be able to fix you up here with what our plan is. But hormones don't fix everything, right? It could be multifactorial. It could have one thing from each column, but it really can really get people there. We covered some good ground here. We've been chatting for coming up on an hour. Two quick rapid fire questions for you that are kind of side related things that are just super common questions people ask. So if you get you were talking about young guys. So if you have someone coming in with fertility concerns, and maybe it's not immediate fertility concern, but it's a young guy. He's like, I don't know, I'm in my late 20s, early 30s. I'm not married. I'd like to be. Sure, maybe I want to have kids. I don't know, maybe not. Testosterone's low. They're symptomatic. How do you handle fertility with this guy? Do you start him on HCG right away? Do you tell him to wait until they're ready to closer to wanting to conceive? How do you handle a patient like that?
Yeah, I think those are the more difficult ones, aren't they? I think at the end of the day, I'm quite a fan of people making informed decisions. So I would say to them, number one, it'd be good to get, it's important to get a baseline sperm count, because you may have, you might have good sperm count before you go in. You might have poor, and if you have poor, then it's probably going to make things even more complicated and difficult to work out the future planning. I would suggest, you basically give them the information as to the roles of testosterone, the likely suggesting that it's likely going to make conceiving much more difficult if you're just taking testosterone by itself, and then looking at fertility protocols, HCG plus or minus recombinant FSH, which is not, it's expensive here, but it's not too crazy expensive, and just kind of laying out the options ahead of them. So if they went for, let's say, testosterone and said, right, well, in the future I want to look at fertility, and let's say we got a good baseline sperm count, I wouldn't start HCG from day dot, just because I think it muddies the water a little bit too much in terms of there's a significant proportion of guys who get side effects from HCG. So I like to say dial the testosterone in, and then we'll add HCG in and see how you respond to it. And then closer to the fertility window, that's where you'd be thinking about checking sperm counts, adjusting, because the maintenance HCG dose is rarely going to be enough for fertility. So you might need to be ramping the HCG up, adding other fertility protocols in. I think ultimately, from my experience, I don't know if yours is the same, Mike, but it's like if their baseline fertility is decent, then I think with a good fertility protocol down the line, they should get a good sperm response. I certainly did myself for my third child. I had a very robust response to HCG and FSH. But a lot of guys do have a good response. It's key for them to know the ins and outs. That's what I'm kind of like fairly libertarian in that sense, in terms of like, you're an adult, so this is what I would describe as the options here. Let's roll from here. Yeah.
Yeah, no, I think that's great. And like a lot of other answers, is not this is it. Boom, this is the one option, and this is what I do with everyone. Because you're right, a lot of things come into play. There's the ACG has gotten cheaper here again, and more available. But for a while it was a cost concern. Same thing with FSH. It's available compounded and not absurd like it was. Certainly not as expensive as a kid's going to be over its lifetime. So there's that as your first investment. But I like your idea of saying, you start too many things at the same time, you don't know what's making you feel bad or making you feel good, right? Which one is it? We added HCG with your TRT. Oh, I feel like garbage. Well, damn it. What are we going to do here? Do we need to change the dose of something? We need to remove something? So I do like the idea of giving it some time, then adding it in. I like the idea of just kind of keeping the tap on for guys who have, if they have some, if they're on the young side, or they're putting it out there as a possibility. Like, hey, for your extra small investment per month here to pay for your HCG, it's not going to cost you a whole lot. Maybe just keep it trickle if you tolerate it, and if you don't, probably not the end of the world. Right, could probably get you back anyway when we need to. So I like that. I like your approach there. I like your approach. One last bit that comes up all the time, and it's something I see people kind of, dance around, or they're afraid to answer straightforward, is, you get a guy with a high hemoglobin and hematocrit. Mm-hmm. And is there a cutoff number where you're honestly concerned and you're like, I'm sending this guy for some phlebotomy? I left that a little bit open-ended on purpose, because I know there's some other stuff. But is there a number where you see it and you're like, oh, I'm making the call, I'm sending this guy in?
Yeah, I mean, the phlebotomy one is fascinating, because I've obviously for the book I've read a lot about the hematocrit and was kind of looking at the data on it, and it's just kind of like it's as clear as mud. It really is. It's kind of like, if you look at it, hematocrit as an independent risk factor for things like clots and things, I just don't think the evidence is there to say, particularly, for example, you take guys who live at high altitude, hematocrits, I've seen a study that I think they were in the 60s, the average hematocrit, no increased rate of blood clots and things like that.
Andean Highlanders or something like that.
I think it was. But I suppose the question mark comes into people's mind is, well, number one, if something happens, then how do you stand this up in court when every guideline talks about hematocrit of 54 or below being, the cutoff point. And the big aspect thing I think that often gets missed when people talk about hematocrit is, some elevation in hematocrit is likely expected with TRT. And let's say it's less of an issue in the UK, because I think you guys got people obviously at high altitude in certain areas of where you guys live as well, depending on what state and things like that and the geography. But the other thing is you have to look at, is there a contributing health issue? So if for example, if a guy's got obstructive sleep apnea, yes, and they've got a high hematocrit, well, if there's a higher rate of bad outcomes, it's probably the sleep apnea rather than necessarily the hematocrit. It's more of a signal. Same thing with, I would say, a lot of the guys who have a raised hematocrit on TRT, maybe they're not apneic, or maybe they've not got OSA, but maybe they're just poor health in terms of insulin resistance and things, because there is a bit of a correlation between insulin resistance and hematocrit response, and sort of like an exacerbated response. So I don't know if I have necessarily a cutoff point. I think in the last year I've probably sent 2 guys for blood donation, and that was after discussing with them, and that was more for symptomatic relief, because they said to me they felt a certain way. So that was kind of like, well, if you do this, it might help you feel better. Some guys do find that, some guys don't. But generally speaking, you're looking at, why is it raised? Is it purely TRT driven? And then again, my always cop-out answer is, I tell the patient, here's what the guidelines say, here's what I think, what do you want to do about it? That's essentially how I play these things, because I think at the end of the day, if someone's able to take the information in, and because we've got time with patients, I'm able to kind of give them the guideline levels versus what I think. And obviously a key aspect, side point of hematocrit is making sure people are hydrated, because most commonly they seem to be bloody dehydrated when they get it done, and you repeat and it's normal. But Yeah, that's my waffle. I don't think it's a clear answer, but I kind of give them the information and say, dealer's choice in a sense. What's your preference with that information?
Yeah, I think that answer was clearer than most, and definitely more reasonable than a lot of treatment I see. I see a lot of docs in the U.S. So yeah, you'll see that 54 quoted in some of the guidelines. So they see that as a hard stop. No, they just stop treatment completely, restart it in a month at a lower dose. Yeah. Plus, they make them phlebotomize. Like, oh no, come on, man, what are we doing?
Yeah.
So if anything, if I see it running high, and again, I'm not worried about it. I'm expecting to see a 10% increase, give or take. So if that's what we're seeing happen from your baseline, then no one's surprised, and who cares, right? It's not a big deal. Mm-hmm. I ask about symptoms too, right? It's always tricky asking about symptoms because you might be planting a seed. It's like, maybe my vision is a little blurry. Maybe I am feeling a little foggy in my head. Maybe, I am having headaches. Like, okay, well, we could try it and see. But yeah, very, very, very rarely do I. And again, you mentioned sleep apnea too. We don't make people phlebotomize just for elevated H&H with just sleep apnea. They come in high. The doc sees that, like, oh yeah, it's your sleep apnea. Let's get that tuned up. It's not like, oh my God, we better get you. You're going to have a stroke if we don't get you some bloodletting right away. I think one of the only ones I've seen in the literature was a cutoff number of 65% for hematocrit. And this was like for congenital heart failure, with hypoxia. Like, where is this a problem? And they called 65%. They said they had some small data set on, hey, we see more clots in this population. That's a pretty special population. Again, you can't really compare and see. So yeah, it's an interesting one. It's going to be an ongoing back and forth for forever, I think, with this.
Yeah, I think the thing that frustrates probably you and I and a lot of us in this space is this kind of hard and fast blanket black and white response to the hematocrit issue that so many physicians seem to have, or clinicians, is saying, if it goes above this level, you must do this because we know that it increases your risk of clots and blood clots and strokes and all of it. It's like, the very least you could say is that's debatable. I think the fact that you're giving it a black and white coating is just not true. And I don't like confidence when there's a lack of data to make you confident in something. That really bugs me, because it's basically just behaving like you know something that someone else doesn't, when it's actually like, well, actually, no, I've delved deeper than you, and I understand that this topic's not as clear cut as you're making it out to be. That's what frustrates me.
Yeah, it's tough too. I think some of these providers don't realize they're losing. Their patients are losing confidence in them if you say things that are ridiculous or you can't back up or you're not willing to budge on. They're like, well, what else? Yeah. What else are you getting wrong? Do I trust this guy at all? I'm trusting this guy with my health. What's happening here?
Yeah. Well, I think the same thing comes in, like, we don't want to get too deviated, do we? But like sort of diverted. But the same thing comes from like high estrogen and saying, oh, if you have high estrogen, you're going to get X, Y, or Z. And it's like, that's like bro science. Like, that's not even like, again, it's just kind of like, it will cause. I've even seen an Instagram reel earlier today where it was like, too low or too high estrogen will cause erectile dysfunction on TRT, and I thought, well, hang on a minute, let's go through this in a bit more depth here. And I just think it's the problem is that confidence and black and white answers tend to sell, don't they? So people like this idea that you have all the right answers, whereas actually that nuanced element where, particularly with hematocrit, you come back to it and you think, this is what the guidelines say, this is what there's other evidence to suggest this, like we're saying about like people living at high altitude not demonstrating, they're not dropping over from clots and things. That nuance gets lost in sort of these short and sharp conversations online or these short and sharp conversations in clinic when you've got 10 minutes with people. I think the benefit of having time and actually speaking to a real person who looks at things in a wider sense, you actually have the ability to kind of go through the ins and outs of it. And at the end of that conversation, if they want to then do something about their level or their result, well, fair dues. You've made an informed call. You've made an informed decision. I think the idea, I hope people are getting away from this idea that because of X side effect, you stop treatment. That again, if you come back to the basics of, if you just remove the word testosterone and replaced it with thyroid, if someone came into your clinic and they said, I'm getting palpitations, I think my thyroid dose is too high, and then lo and behold, their blood show their thyroid levels too high. Would you stop it? Because presumably they need the thyroid hormone because they're on it. So would you not reduce the dose? It's kind of this concept of like, people get stopped their testosterone replacement because of a side effect rather than an adjustment made. And it's kind of like, again, if a type 1 diabetic has a hypo, you don't stop them ever again taking insulin. I know it's a bit more extreme scenario, but it's this sort of idea of it's hormone replacement. You can't just stop and start it because of a side effect. You need to actually kind of manage the protocol rather than just pulling it because you sort of think that, no, that's a side effect. We can't deal with that. Thank you. It's a bit weird. And so testosterone, again, is in this world of its own, the way that we look at it.
Yeah, and I'll explain to my patients too who run into that with their other providers. I'll say, it's just what they're proposing isn't a sustainable plan. Like we're going to stop your testosterone every time your hematocrit's 55% for a month, and you're going to feel like crap for a little while, or we're going to get just back down below, or even with donating blood. Okay, so we're going to game the system. We're going to have you donate, and then we'll recheck it when it looks nice, and then it's just slowly coming back up in the background anyway as your ferritin is tanking simultaneously. So, and a lot of them seem to understand that. But yeah, so it's an interesting one. Yeah, thanks for stepping into the fire to answer those. They're tough.
I always say to them as well, do more cardio and drink more fluid as well. That's another thing, because sometimes if people get fitter, you'll see their hematocrits and things improve alongside other, their HbA1c improves, their lipids improve. So a lot of this stuff, even with hematocrit, I think there is a lifestyle element to it. You don't tend to see lean, fit and active guys get particularly elevated hematocrits where you'd ever sort of think, oh, that looks a bit, what do I do with this? I'm going to have to at least discuss this with them. You rarely will see that.
Yeah, no, and I'll tell guys too, the whole concept of sports anemia. We get these super high, high level, mega endurance athletes. They actually will get, they get this dilution, and they have low, their H&H is actually on the low side. So I tell them, we're not shooting for that. I don't need you logging, 100 miles a week on your bike or some sort of crazy thing. But we'll split the difference. Have you do some zone 2 cardio 4 times per week, 30 minutes, and we might be, knock a few percentage points off, and everyone feels better about it. And now you're healthier on top of it. So there could be something there.
Makes you feel better anyway, doesn't it, cardio? I think that's what's good about cardio. I think it probably makes you feel better than resistance training in a way. We don't like doing it. It's not as fun as weightlifting, but I think the afterglow might be better. At least that's my personal opinion to it. Yeah.
Oh, no, for sure. Yeah, I definitely prefer to lift some weights and do some cardio, but I feel better after every time I do some cardio.
Yeah.
We have a bike out in the garage, and we don't turn the AC on out there, so it's 100+ in Phoenix, and it feels good when it's over. It actually feels good while you're doing it. You're perfusing your brain a little bit, a little time with your thoughts. So it's a good thing. Again, I tell people do it anyway. I don't like it, but I do it anyway, and you should too. So it's good for you. It's good for you. Excellent. Excellent.
The analogy is like you said about kids before. It's kind of like, my kids don't want to eat their vegetables, but they still eat their vegetables because it's good for them. So Unless you're in the carnivore wagon, in which case vegetables potentially are good for you, but I think they are good for them, so I make them eat their vegetables. Yeah, it's the same thing with lifestyle. You might not want to do these things, but it's best for you to do it, so you probably should still.
Yeah, I made what was perceived as a negative comment about carnivore, maybe last week on one of the boards I'm on, and someone was surprised. Like, really, I don't strike me as being anti-carnivore. I was like, I didn't say I'm anti-carnivore. I just said there's some real wackadoos out there with it. They take it a little too far. Vegetables are not trying to kill us. Mm-hmm. I think there's one of the guys who's a big proponent of it. He would say that the vegetables are literally trying to kill us. They have some, there's some biochemical thing in there, and they're after us. That sounds a little paranoid, man. I think it's okay.
I think it's fascinating. I love the nutrition side of things is really interesting. I mean, on a personal level, over the last 6 months, I've made a real conscious effort to eat more fibre, which is kind of the opposite of the carnivore way. But I've been back and forward with all those different types of diet in terms of reading about them, and I think it's all really interesting. I think long-term carnivore stuff is going to be fascinating to see. I think again, it's one of those things where to say black and white, we know X, Y, and Z would probably be you can say that long-term fiber seems to be good. People who eat good fiber levels seem to have good health outcomes, but then some of the shorter-term studies on carnivore aren't too bad. It's interesting, really. There's probably not a black and white answer to it, but right. I personally eat plenty of fruit and veg.
Yeah. And I always like these, call things targeted nutritional interventions. For some things, I think carnivore. I can't think of a better elimination diet. We just have you eat just meat, water, and salt. I mean, that'll fix your gut. I've done it myself. My gut's just off. I'm like, for 3 months, that's all I'm doing. Boom, fixed a lot of stuff. Felt great. I didn't do it forever. It worked for what it was. What it was good for.
And insulin sensitivity as well. Yeah, it's sort of like you do see a lot of insulin sensitivity responses positive to it, obviously. So it's certainly it's like anything. It's sort of maybe a time and place.
Yeah. But if it makes your your LDL cholesterol 300 and you have a positive calcium score, maybe it's not. Maybe we're not on the right path there. Yeah. Maybe we can have another chat one day, a lipid round table or something, and get people upset about all that too.
Yes. Yeah. Exactly. Get our statin money in. Yeah. Exactly.
That's right.
Yeah.
That's right. Yeah. I don't think Big Pharma has the wrong address for me. I haven't gotten my check. I'm going to give them a call, make sure they forward it back to me.
Yeah. Good stuff.
All right. Yeah. So we've been running a little while over here. I appreciate your time. So maybe we'll wrap it here. Leave us something to chat about next time. And then where can people find you? Anything upcoming we should know about? Tell us what we can do. I'll put some links below in the description.
Yeah. So the two companies I work for are sort of Alphagenics and MyAtlas. So they're just alphagenics.co.uk and myatlas.co.uk. And obviously Instagram tends to be where I'm more active. So if people it's at Dr. Max Draper on there. I think I'm on Facebook and LinkedIn. I just don't tend to log in very often for those. But that's where people can reach out and find me. And obviously through the companies is where you'll sort of arrange a consultation or something if you're in the UK area, essentially.
Gotcha. Oh, yeah, I think I only mentioned the one clinic in the intro. I hope the other one doesn't give you some pushback, give you a hard time. Okay, man.
Oh, that's all right. Yeah, don't worry about that.
And as soon as you said it, too, because I see your videos, too, with both. Yeah. With both, too, so it's obvious. Sorry about that.
Yeah.
No bias. No bias. So could you basically do telemed anywhere in the UK, or what kind of reach do you have?
Yeah, exactly. So in the UK, so it covers the Scotland, Wales, Northern Ireland, and England. So it's got quite good coverage. Not Europe as such and things like that. I think obviously Dave Lee has a clinic that covers a lot of the Eastern Europe, but I'm not involved with sort of Spain, France, all of those places. So I don't know what people do in Europe, to be honest. I don't know if there's clinics out that way in Western Europe. I mean, but yeah, UK for me.
It seems hit or miss. Can people fly in from other countries? I mean, can people fly in from European countries and see you and establish care in some way, and then get treatment or bring their meds back with them? Or do you have guys who do that?
Yeah, they'd probably have to more sort of seek you could give advice-only consults pretty much to people abroad. Yeah, because the European Union is kind of like a separate entity when it comes to medical stuff. Yeah.
Gotcha. Yeah, we had I'll just last thing I'll wrap on because I think it was kind of funny. We had a guy comment. We were talking to him on one of the live shows. He's from Sweden, and his doctor, he hit a total testosterone of 600, so they cut him off. They said, "You're too high," and that was it.
Yeah.
That's interesting. Yeah, so talking about finding some good care, I think it could be a little tricky in some countries. I think we're pretty fortunate in the U.S. Maybe too fortunate. There's a lot of places kind of not doing it the way I would like to see them do it, but at least it's widely available.
Yes, yeah, got good availability, 100%. Yeah, different to the rest of the world, I think, to be honest. Yeah.
Yeah, for sure. Awesome. Well, Max, it was great chatting with you. Thanks again for coming on, and hope to have you back on again sometime.
Pleasure. Be happy to come back on. Thanks for having me.
Awesome. All right.